Well, friends, welcome to today's session. And we have Dr. Deepti Shastri from Vinayak Mission Medical College from Salem. She'll be speaking on early clinical exposure and anatomy. Over to you, Dr. Deepti.
Thank you, sir. Good evening, everyone. Well, what you see on screen is a scene straight out of any anatomist's life. We put in a lot of efforts to make students understand anatomy using all the skills that we possess, like this anatomist on this screen. And what goes on in the mind of our students? Our students think, why do I have to learn this? It is so boring. I thought I was learning to be a doctor. And so, medical students join the course with a lot of hope that they start treating patients from day one. This meme rightly depicts the life of a first year medical student. His friends think that he takes care of emergency situations like this. His family thinks he's a noble professional. His teacher thinks that he's working hard studying what's been taught. Society thinks he's a noble doctor. He thinks he's like this character straight out of a serial who inspires a whole lot of other professionals. But what he really does is sleep over an enormous number of books he doesn't have a context to study. And hence, early clinical exposure has made its entry. It is a component of the first year of MBBS program, which has been introduced with the objective of providing opportunities for students to develop the ability to learn concepts with their future application. This will definitely generate interest and provide for greater retention and comprehension in the learner. I am Dr. Deepti Shastri, and I'll take you through ECE module for the next 45 minutes. The objectives of my session are, by the end of the session, you should be able to define ECE, explain the elements and rationale of ECE, state the salient principles of ECE, plan the teaching learning methods, which includes the structure of the program, construct formative and summative assessment methods for ECE, initiate capacity building measures for faculty, and develop ECE modules in anatomy. So what is early clinical exposure? As defined by Donnan et al., Medical Teacher 2006, early clinical exposure is an authentic human contact in a social or clinical context that enhances learning of health, illness, and or disease, and the role of a health professional occurring in the early or preclinical years of medical school, usually the first 2 years. First 2 years because the author is not an Indian, where the first MBBS is of 1 year course. There's another definition given by Elizabeth Kay in Medical Education 2003 about what is ECE. She describes early clinical exposure as a teaching learning methodology which fosters exposure of the medical students to patients as early as the first year of medical school. So early clinical exposure acts like a bridge between the preclinical disciplines and the clinical disciplines. In ECE, the students learn both basic and clinical sciences using integrating learning activities such as early contact in hospital or community settings, communication skills, problem-based learning sessions. Early clinical exposure enriches and contextualizes the learning of basic and clinical sciences and offers a wide variety of teaching learning methods. Why is ECE necessary? Students look forward to dealing with patients and learning how to take care of them. Preclinical experience is far removed from the purpose why they have entered medicine. It is difficult for the students to correlate structure, function, and metabolic processes without seeing patients and understanding the purpose of what they are learning. So the elements and rationale of ECE is ECE enables the learner to recognize the relevance of basic science in diagnosis, patient care, and treatment by providing clinical correlation to basic science learning. Provision of authentic human contact in a social or clinical context enhances learning in preclinical years. Introduction of humanities in medicine makes them understand the socio-cultural context of diseases through the study of humanities and social sciences. Authentic human contact, in fact, enables the learner to relate the experience of patients, which in fact motivates the students to learn better. It also helps them to recognize attitude, ethics, and professionalism as an integral part of the doctor-patient relationship. The salient principles of ECE are the key principle, in fact, that marks ECE are to provide a clinical context and ensure patient centricity. Clinical context should preferably be with the presence of actual patients, but it can include case scenarios, which can be paper-based, videos, simulated patients, investigation reports. The purpose of ECE is, however, not to prepone the conventional clinical teaching, but to provide better understanding of basic sciences through a clinical context. So, where to use ECE? There are three basic settings that have been suggested by NCI. One is classroom setting, hospital setting, and community setting. In classroom setting, case discussions can be encouraged with patients being brought to the classroom for an authentic human contact. In hospital setting, students make hospital visits and are exposed to primary care by healthcare professionals, including paramedical staff like nurses, physiotherapists, healthcare workers, etc. In community setting, students are exposed to not only the patients, but their social conditions, economic status of the patients, and the community in which the patient resides. In all three types of settings, the students can acquire basic clinical skills and can be demonstrated clinical problems. However, the context to their learning should always be the focus, and the relevance of the clinical case to basic science needs to be emphasized. The structure of the program is such that the time allotted for ECE in the first year, as per GMR 2019, is 90 hours, which is equally divided among the three preclinical subjects. So the total number of hours available for anatomy is 30 hours, which is further divided into 18 hours for basic sciences and 12 hours for clinical sciences. It is recommended that 3-hour sessions once in a month for 6 months be accounted for basic sciences and 3 hours per session once a month for 4 months for clinical sciences. In case of basic science correlation, it is suggested that the clinical context be introduced by actual patient contact or by use of charts or by X-ray. Earlier you had seen that the X-ray was in a demonstration room, but they could see an X-ray in the clinical setup, or they can have paper-based cases like the one projected. Clinical sciences. The students need to experience clinical science in human context, and this accounts for 12 hours, 3 hours per month for 4 months. Here, the students could be divided into small groups if feasible and should possess observation guides or checklists. Cases can be demonstrated to them in wards or in OPD or in demonstration rooms themselves. Clinical cases can also be projected with the help of videos. I'm going to project a video now. It didn't work earlier. I hope you can hear the sound. If you can't hear the sound, I'll just mimic the words. So this is a doctor who is asking the details of the patient, and he's explaining that he's going to examine the patient. He's explaining to the patient that he will come close to the patient and examine his neck and has taken consent from the patient. He then observes if the patient is agitated or anxious. He asks the patient to put forward his hand to check for acropathy, which is a dermatological feature in hyperthyroidism. He also checks for tremors by placing a paper on his hands. He asks the patient to turn his hands and looks for dry skin and palmar erythema, which are all signs of hypothyroidism. Looks for sweating. He takes his permission to feel his pulse and thanks the patient. Then looks for features on his face, looks for dry skin and loss of hair in the outer third of eyebrow. He informs the patient that he will look into his eyes and asks him to look at the wall opposite and looks for exophthalmos by looking at the side of his eyes. Then he tells him he's going to look at him from behind. Then he informs him that he's going to ask him to make movements of the eyes. He gives him directions to follow his fingers. And thanks the patient. He informs him that he is looking at his neck and looks for any mass in the neck. He asks the patient to take a sip of the water and to swallow. He asks the patient to protrude the tongue and then informs him that he's going to feel his neck. He palpates the mass in front of his neck and asks him to protrude his tongue and asks him to sip water once again. He informs him that he's going to look for glands in his neck. He informs him he's going to feel his windpipe and he may feel uncomfortable. He informs him that he's auscultating and he asks him to take a deep breath. He tells him that he's going to check his reflexes and asks him to position his forearm accordingly. He asks him to roll up his trousers because he's going to look at his shin. He asks him to stand up and cross his arms. And he thanks the patient. Um, so that ends the video. So what you got to see is that though the student did not have an authentic patient contact, in the video, the student got to observe the professional attitude of the doctor, how movements of eyeball are tested, how the patient was asked to swallow by sipping water, how he was asked to put out his tongue, why the extent of lobes of thyroid gland are important, uh, since the doctor asked the patient's permission to examine the extent of the thyroid gland, and how a retrosternal goiter is identified by percussion, how the doctor looked for lymph nodes in the neck, and how he looked for the trachea. So the points that we need to consider while planning ECE are: what is the student being asked to observe? What prior knowledge does he have? What might he learn from these observations? So the onus of developing ECE is on the faculty. And these are the points that we need to consider while developing ECE modules. For example, taking the same case of thyrotoxicosis and hypothyroidism, we can develop an observation guide where we need to know that the student has to watch as the doctor examines the patient and see if he can identify any typical features of thyrotoxicosis. He has to think about the basic science correlation between his presenting symptoms and signs. In the MCI ECE booklet, examples for observation guide are mentioned in Annexure 2. This is one more observation guide that we could develop. We can ask the student to watch as the doctor demonstrates how to ensure it's a thyroid swelling by asking the patient to swallow. And to watch how he demonstrates to palpate the thyroid and correlate the method of palpation with the anatomy of thyroid that he has learned. Preclinical faculty should keep in mind that debriefing is essential after every session. Now, how do we plan conducting ECE? A plan is always warranted for every ECE session. A 3-hour ECE session can follow the following guidelines. First 30 minutes could be devoted to introduction to the specific module and instructions for the session, which could be delivered by the preclinical faculty. And this is followed by the clinical experience. It could be in any of the setups mentioned earlier, classroom, hospital, or community setup. The students need to carry their observation guides or checklist. And this clinical exposure would last for 1.5 hours. This is followed by a summary and conclusion with learning points. This can be elicited from the students by posting review questions by faculty so that they are engaged till the end of the session. And this could last for 30 minutes. And this is followed by reflection with guidance and monitoring by faculty and what was already learned by the student. The MCI ECE document makes a mention that humanities and medicine is merged with the AdCom module. So no specific time has been allotted to humanities in the ECE module. I would still like to add a few slides on humanities and medicine. The competency which is addressed by introduction of humanities and medicine is the learner must explore, discuss, and reflect on human illness, suffering, and medicine as portrayed in literature, either classic or contemporary. And today, I will focus on a few contemporary literature items. Gifted Hands is by a brilliant pediatric neurosurgeon, and this book takes you through the journey of the trials and tribulations Ben Carson underwent from his childhood, poverty stricken, and then the life that he has now, the success that he is today. He works in Johns Hopkins University. Atul Gawande is a surgeon and a prolific writer and has authored many books to his credit. This book, Being Mortal, explores why doctors struggle to discuss end-of-life care and death with patients. I'm sure all of you are familiar with this book, When Breath Becomes Air, by Dr. Paul Kalanidhi, an American neurosurgeon. It is a memoir about his life and his illness, that is metastatic lung cancer, and what he went through and his family went through. So these are books. We also have movies that all of you are familiar with. Patch Adams. There's one called as My Sister's Keeper. It shows how this girl who is made to donate her bone marrow to a sibling resents it. Serials like House, Grey's Anatomy, and Korean drama like Doctors. They all deal with doctor-patient relationship, attitude, professional behavior, and it is good for students to be introduced to the life of a doctor through literature, movies. and so on. The students can use all these movies and books as resource material and finally reflect on them and pen their narratives. In fact, our institution has developed an innovative method of narrative-based education, which is called as Fresh Notes for the interns. And it uses movie scenes and reflection by students to narrate a script that involves doctors from all these movies and books. Well, it is not just movies and books that can inspire, but paintings can motivate learners too. You might be familiar with Frida Kahlo, uh, especially because Deepika Padukone dressed up as Miss Kahlo for her wedding reception. Well, Frida Kahlo had polio in 1913 and had limb and spine deformities. She's a very well-known person for her artwork, which included illustrations in anatomy. This is a book which has been written in her honor. Rudyard Kipling and his 6 honors serving men, what, why, when, how, where, who, is the favorite of all of us who have read Park and Park, the PSM textbook, community medicine textbook. And how can we forget the quotes and poems dedicated to anatomy in B.D. Chaurasia's textbook of anatomy, or for that matter, Leonardo da Vinci? Well, let's move on from humanities and medicine to early clinical exposure versus integration. As far as integration goes, I've just begun today where Dr. Angela left off. By now, you're familiar with ITO and integration components. Early clinical exposure is a teaching learning methodology which stands at correlation in Hardin's ladder of integration. This is an example of a linker that has been given which correlates all the basic science subjects together. You're familiar with the integration illustration as well. So early clinical exposure is a correlation. There's a linker, which is a clinical condition in early clinical exposure, where the basic sciences are correlated to it. Dr. Praveen Iyer sir always points out that we generally integrate at all levels during the course, especially nesting, as applied anatomy has always been a part and parcel of anatomy teaching. It would be interesting, however, for me to know if any of the institutions have followed this kind of linker session, where 90 hours has not been divided between the 3 subjects, but it is used as a combined 90 hours for all 3 basic science subjects together. A common linker is used to connect anatomy, physiology, biochemistry with the linker. At the end of my session, I would like to listen to the faculty who have done this. We again have a method which is called as Vin Mantra, which stands for Vinayaka, that's our institution. Mantra stands for Module for Academic Networking and Training. Here we give a linker session to the students, and the linker involves all 3 subjects, like for example, diabetes that is given here. And the faculty of anatomy, physiology, biochemistry, they plan the session along with a clinician, a physician, and then the linker is given to the students with review questions on anatomy, physiology, and biochemistry. The students are divided into 2 parts. One half goes to the central library. We make them use resources in the central library because we find the students are more virtual and digital as compared to reading books. So we send them to the central library and they find the solutions to the linker problem that is given to them. And the other half, in fact, uses internet to check for answers and also use the departmental library to go through it. We give them 7 to 10 days to work out this problem, and they do it on WhatsApp. The students discuss the problems by themselves. They are divided into 10 groups. We have 100 students, and the faculty just act as facilitators and don't interfere in the discussions of students. And after 10 days, the students actually do a presentation. And when they present, we permit them to use any kind of mode of presentation. It could be role play, it could be a painting, it could be models or PowerPoint presentation or Blackboard. So this is how we link all three subjects with the clinical science. But we have just 1 or 2 sessions of these. We all know assessment drives learning. So it is imperative that assessment plays a major role in early clinical exposure as well. So formative assessment of early clinical exposure can involve periodic assessment of logbook entries, or the students can maintain portfolios which can be assessed. There will be a separate session on logbook as well as portfolio maintenance. It is suggested by MCI that internal assessment exams as well as university exams must include elements of early clinical exposure to test the ability of students to apply basic science knowledge in clinical context. Hence, the type of questions that can cater to this aspect of early clinical exposure are problem-based long answer questions, clinical vignette-based short answer questions, problem-based multiple choice questions, or OSPE. I'll just give you samples of each of them. You can just go through it yourselves. So this is an example of an MCQ. An example for short answer question. And this one for long answer question, a modified long essay. So MCQ caters to objective type of question, but there is a problem-based STEM. Short answer question actually checks application of knowledge, and long answer question, comprehension as well as analysis. So all of them have a problem base as a STEM, but then it is basic anatomy as the answer. This is just an example of an OSPE station where a problem is given to them, and the questions that they need to answer are more practically oriented. So this is about assessment of early clinical exposure. Introduction of any new teaching methodology needs capacity building of faculty. Capacity building involves preclinical and clinical faculty working in tandem during planning of sessions. Preclinical faculty need to be oriented to developing skills for implementing and assessing early clinical exposure. They need to learn to set problem-based questions. For implementation, monitoring, and curricular governance, just like the rest of CBME curriculum, the dean needs to head. The curriculum committee can initiate the discussions on early clinical exposure modules. Curricular subcommittee can oversee the implementation. Medical education unit can monitor along with the heads of departments and the faculty members of each department. We now move on to how ECE modules can be designed. While designing an ECE module, the following have to be kept in mind. What is the setting, whether it is classroom or hospital or community setting? The learning objectives must be stated. Learning experiences must be planned. Planning of implementation is to be done. What are the challenges faced and the measures which help to overcome the challenges need to be discussed. And finally, ECE module needs to be evaluated. This is an annexure that has been given in the ECE document, annexure 4 for varicose veins, which includes everything. So you can go through it at your leisure time. So I've come to the end of the session. What we expect out of all the groups is we need you to develop ECE modules in topics which are selected by respective resource faculty. This is a template which is supplied by MCI in the Curriculum Implementation Support Program 2. It will be made available to all of you to work on the ECE modules. Each group needs to develop just one ECE module, including competency, objectives, teaching learning methods, resources needed, feedback, and assessment. And you also need to develop an observation guide. So this is the list of topics that have been chosen by respective resource persons, and the topics that will be given to you by your resource faculty. This will also be posted in the WhatsApp groups after this session. So to summarize, ECE is a teaching learning strategy. Introduction of clinical content is in order to enhance relevance and understanding of basic science subjects. Students are motivated to learn with deeper understanding of subjects with introduction of ECE. I would like to end by quoting the chairman of the Board of Governors. He has mentioned that this booklet incorporates some ideas and best practices which have been gleaned from experts and institutions across the country. And the Chairman Board of Governors is confident that all the institutions will add to this corpus of experience, their own lessons, cases, and modules, and hopefully share them with their institutions and other institutions. This is actually in the foreword in the ECE module. So I would like to quote Dr. Munira A. Hirakani, who says, "Many ideas grow better when transplanted into another mind than the one where they sprang up. So keep sharing best practices with each other and with us." Thank you. I'll be happy to take any questions.
Please raise your hands. मुझे तेरा लैपटॉप की चार्जर कहाँ है जल्दी से मुदित please raise your hands. Neha, can you take over?
Yes, sir, I can.
Yes. My battery is slightly low and please.
Sir, but there are no hands right now.
Yeah, there are Dr. Anuradha Barua.
Yeah.
Shilpa Batla.
Sir, I have unmuted Dr. Anuradha.
Yes. Dr. Shilpa, can you speak?
Yes, sir. Am I audible, sir?
Yes.
Hello, ma'am.
Hello, ma'am.
Ma'am, thank you for a wonderful presentation. Many concepts have been cleared. Just one or two things, ma'am. One thing is, ma'am, when we talk of the reversal of roles, I think what I've listened and heard and learned in this module is that what happens when we go reverse? How will the clinicians incorporate basic teaching in the third and the fourth years? Will it be a part of a reverse ECE?
You mean to say when the students go to clinical years?
Yes, ma'am.
It wouldn't be called reverse ECE. It is correlation of basic sciences to clinical sciences. I'm sure they are doing it even now. The students have always had a relevance of basic science to clinical science when they are in clinical years. But that has been missing earlier in preclinical years. So that's a nice word you have coined, reverse ECE. It will be called early clinical exposure in reverse. It's just basic science, revision. I think Dr. Girija was actually making modules for interns on anatomy.
Okay.
No, what you're suggesting, the reverse ECE, Dr. Deepti Shastri, I think it was a famous project where she was making basic science modules for interns. So what you say is right.
Because we tend to forget these basics as we move ahead, especially when we are planning, hernia surgeries, especially if we can have very quick revisions. And when we go to clinical subjects, especially surgery, it always says basic anatomy. So, like we are calling clinicians here, we can't have an opposite thing where we are called for the revisions there.
You're right, ma'am. In fact, one of our faculty, Dr. Sendil Kumar, if he's there, he can share his experience. He was also making modules of basic science, especially anatomy modules for interns.
Okay, ma'am. One thing, ma'am, I think I just need a more clarification on that. Do we include ECE under vertical integration? Is it the same? How is it different?
Once again, these are all terminology and we should not get lost in semantics. Again, I would like to quote Dr. Praveen Iyer. He always says that we have always integrated. Anatomies have always integrated clinical science. Applied anatomy has always been a part of our curriculum, and that is called as nesting now. And vertical integration, I'm sure we used to have these linker sessions, one-off on a Saturday. We would have a session on meningitis. We would have faculty from various departments, clinical, from microbiology, pathology, and anatomy and physiology, presenting such sessions to our students. So these are all early clinical exposure is vertical integration, and on the integration ladder, it belongs to correlation.
Correlation, ma'am. And you talked of some debriefing sessions. Can you just little on that? You mentioned a debriefing session at the end of an ECE.
Yes.
That we need a debriefing session. Can I just have 1-2 lines more on that? By what exactly when we talk of this debriefing?
When we start out any learning session, we always set objectives to them. Objectives. So at the end of the session, you need to check if the objectives have been achieved. So you need to discuss with the students the learning points, whether they have learned what they were supposed to learn. So that is what debriefing session is all about, where you summarize and you conclude about the module.
Yes, ma'am. Yes, ma'am.
You need to summarize the activity, ECE activity, and you need to check whether the learning objectives have been achieved by the end of the session. So that would be part of debriefing.
One last question, ma'am. You separated out 18 hours for basic sciences and 12 hours for clinical settings. And what I understand from my point of view is that ECE actually we are giving a clinical exposure. So how is it? How are these 18 and 12 hours separated out?
Again, if you have it in your timetable, 3 hours per week, so that physiology, biochemistry, anatomy all can be covered. You mean, do you mean how we conduct the sessions, or are you asking whether we have to stick to the 18 hours and the 12 hours?
No, what I didn't understand was that the very topic we gave was early clinical exposure. So it means that we are involving clinics. So, and within that we are creating two subsets. One says 18 hours for basic sciences, 12 hours for clinical. So when the term itself says early clinical exposure, where do these 18 hours of basic sciences themselves come in? But basically, how is it conducted? That is the...
So those 18 hours is why they insist on basic science correlation is that it can be conducted by preclinical faculty.
Okay.
You need not get a patient to the classroom. You can use these reports, X-ray reports or investigation reports, ultrasound reports, or you can have a paper-based case, and you have review questions which are related to anatomy or physiology or biochemistry. So you do more of correlation of the science to the clinical context. But in a clinical setting, when they go to a hospital, they not only observe the patient, they observe the doctor-patient relationship, attitude. So the professional behavior attitude of the doctor can be observed in a clinical setup, which is missing in basic science setup. Dr. Anuradha?
Yes, ma'am.
Do
you hear me?
Here? Yeah, now I can hear you. There was a lot
yes,
of background sound. So what I was trying to say is that when the student goes to the clinical side, he not only observes the patient and correlates, the anatomical basis of a clinical condition, but he also observes the doctor-patient relationship and the professional attitude of the doctor. So that would be missing in a classroom setup.
So what do we expect as reflections on early clinical exposure?
Again, you have to set the objectives for them. You have to give observation guide. Only then they will be able to mention, like what they observe. If you're not set the objective, he could be observing a patient in a neighboring bed rather than the patient you sent him to watch. If you have not set the objective that, for example, I'll take this video that I posted on thyrotoxicosis. If you have not set the objective that the student needs to know the applied anatomy of the swelling moving up with deglutition. Why does the like how does the doctor check that the swelling moves with deglutition? If that was your objective, then when he reflects, he will reflect on it. But if you are not set any objectives, he may not observe any of the anatomical correlation that you would have expected him to do. So reflection will be based on the objectives and the observation guide that is given, the facilitator's guide and the student observation guide or the checklist that you send along with this.
Okay, ma'am. Thank you. Thank you for your nice presentation. Thank you, ma'am.
Thank you, ma'am, for your questions.
Santhi, Sandil Kumar.
Thank you, sir. Good evening to the forum. Actually, Deepti ma'am was telling about me only regarding the exposure module. It is a part of my for the need assessment. Students as well as the faculty, they different from another coach to certain level aspects, ossification and all the signs. When they go to their side, the expectance is, so they want basic things to remember throughout the practice. Assessment for project, the they have given basic thing trained.
Dr. Sandil Kumar, I
Maybe
think
that
your
will be different,
net is
ma'am.
your net
Hello,
connection. We cannot hear you properly, Dr. Sandil. Can you please?
hear me, ma'am?
Yeah, it is better now.
So when we go to the clinical faculty, totally different from. So we are, and even it differs location also. Of certain diseases to the regions. Early
Yes.
and according to the disease. So this also should be kept in mind. That is one of the observation.
Okay. Dr. Pushpalatha K. After that, Dr. Dimpy Gupta.
Hello.
Hello, ma'am.
Hello. Yeah, yes, ma'am. It was a good presentation, ma'am.
Thank you, ma'am.
Only one concern in this to conduct the ECE is, so how are we going to achieve the objectives, because it's a small group discussion. So what is the thing we need to look into is like how, because it's a small group discussion, whether every faculty is trained in such a way that to achieve the objectives.
You're right, ma'am. That is why it is important that we have capacity building workshops. And I think it would not be difficult if we orient the faculty to clinical context.
Okay, ma'am.
Did you find it as a challenge, ma'am? Did you find it as a challenge, ma'am? While
little challenge, ma'am, because each faculty has a different competency level. So we find it little challenge in this aspect, because we prepared everything, objective, everything was there, case scenario was given, uniformity was there. But in the when we took the feedback, there was somewhere there was a lagging of this objectivity in all the small groups.
what I feel, ma'am, early clinical exposure is still new to us. We need to take it longitudinally for a few years. We have feedback from students of just this year. So we need to see how much they have gained knowledge when they reach up to the final year. That is our intention, not just for them to study in the first year, but how much knowledge they have gained from first year to final, how much they retain. Unfortunately, we could not listen to Dr. Sandil Kumar speak, but part of his work is that, he's making modules of preclinical subject anatomy for the clinical students, because they tend to forget as well. So if we have early clinical exposure modules in the first year, what I basically feel is we are still not very good at developing early clinical exposure modules. We should develop them in such a way that we take the common cases that are found in the general public, which an Indian medical graduate after he passes out of MBBS gets to see. And in the first year, their 80% of the knowledge that they have should be of basic sciences, and maybe 20% of clinical. And the same linker session should be continued into second year, pre-final year and final year with more percentage of clinical sciences in the later years. That would be
Yes,
more effective, I feel, if we continue with these linkers, we develop very strong, robust modules. That would be more effective. And we need to do a program evaluation later as well. We need to take feedback from the students after they have reached clinical years to find out how effective early clinical exposure actually is.
yes, ma'am. Whether we have met the objectives, we'll be coming to know only when this batch comes out as a graduate. Yes, I
Yes,
agree with you.
ma'am.
Just my concern, because what the
Yes,
problem
ma'am.
is, that's what we could not. The clinicians also sometimes what we felt was exactly when they need to be trained. It's not that nobody knows it, but we need to be organized, more organized, and the faculty need to be trained. We need to stress
Definitely.
on training the faculty.
Definitely.
Thank you.
Thank you, ma'am.
Dr. Dimpy Gupta, Dr. Rajesh.
Good evening, ma'am. Good evening, sir. Ma'am, very well presented. Hello, ma'am. Can you hear
Yes,
me?
Yeah,
Okay.
yes.
yes, Dr. Dimpy.
Yes, ma'am. Ma'am, I just had a question regarding ethical issues in various ways in which we can perform ECE. For example, if we bring, as you told us that there is no need to bring a patient to a classroom, and we can show the videos of common cases. But what we observed was we did 2 sessions of ECE by showing students only the videos and then having a pre-video discussion and a post-video discussion. But what we observed was that the students didn't connect to the videos for very long. So there was inattentiveness. Then we thought of bringing a patient to the classroom. So that unfortunately could not happen. But are there any ethical issues related to that if you bring a patient? Because taking 150 students to any clinic and getting them versed with various patients or in particular a single type of patient becomes a very difficult task, because we need more of residents for that or faculties for that, and we have to do that in batches. So it takes a lot of time and management to correlate between clinical staff and preclinical staff. So what if we call a patient?
Yes, I understand. You can call a patient. You have to take consent of the patient, inform the patient that patient will be examined by a group of students. Uh, Actually, if you're working in a government college, there is an unwritten rule in government colleges that it is a teaching hospital.
Okay.
Even if it is private medical college, if it is a teaching hospital, the patients are aware that their condition may be discussed in front of students. So they are aware of it. But if the patient does not give consent to be examined in a classroom, I don't think you should take the patient to the classroom.
Okay, ma'am. Actually, because in that session, there was a session of where we planned a few lung disorders to be discussed, like tuberculosis and lung cancer and bronchial asthma. So we wanted to just differentiate between these three. So we wanted to bring patients, but we couldn't. And then what we did was, I just wanted to share that we did a role play. The staff members did a play, and that way like one of the staff members acted as a staff a doctor, a clinician. One of the patients was one of the staff was a patient, and another one was a assistant staff nurse. So in that way we could really connect with the students, and we asked students to ask questions to the patient, and that way they can differentiate. So we could build a better connection between the clinical case scenario and the students to engage them for a 3-hour session, if we call it so. And then the post play discussion proved out to be very useful. So I just wanted to know about if anyone else has got any other idea, or if they have implemented any other idea for doing that?
Thank you so much, Dr. Dimpy. Your idea, the sharing of idea has really helped, I'm sure, others as well, because I do understand in government colleges, the doctors are, too busy with a lot of workload. So it is difficult for them to take classes and role play. That's why simulated patients is one of the ways in which you can engage the students. And as you rightly pointed out, a virtual, a video may not connect with the students. A paper case may not connect with the students, but a live person, a simulated patient can help. I think you have given a solution to the problem you said.
Okay, thank you, ma'am. Thank you so much.
Thank you.
Thank you so much, ma'am. Okay.
Dr. Girija Shivakumar. Dr. Mamta Chamalgi.
Good evening, sir. Good evening, Dr. Deepti. In fact, very beautiful presentation. One of the main motivation for me to join this course was you being the faculty member here. You didn't disappoint. I had heard your reflections talk in Coimbatore earlier, and this was again one of the wonderful talk. Thank you very much. I actually wanted to enter in here for 2 points. I think there were 2 questions which were raised earlier. One was, what's the difference between ECE and integrated teaching? The second one was, how do we, or why do we divide this 30 hours into 12 hours in clinical setup and remaining 18 hours in the basic science setup? So the one major difference between ECE and early clear, the integrated teaching would be, in ECE we stress upon our own subject. We only give clinical context to what we are teaching in anatomy. Whereas if it were to be an integrated teaching, let's just taking your own thyroid case as a example, I will take the students to the clinical setup to show a thyroid swelling case, maybe demonstrate them the swelling moving with swallowing or other clinical signs and symptoms. But input from the surgeon describing the features of goiter or surgical repair, those things will not be a part of ECE. That probably will be a part of integrated teaching, where surgeon also has a role to add his subject inputs to that. How much that can be decided between the subjects, but that is where the difference will be. In early clinical exposure, we are teaching only anatomy. We are only giving a clinical context to what we are teaching. Like if I'm teaching inguinal canal, I would like to show a case of inguinal hernia to the patients, which will make my teaching of inguinal canal more meaningful to my students, or it will give a context to my student. So that is one point I would like to clarify. Second thing was, why 18 hours and 12 hours? In fact, if possible, we should be taking our students to clinics for all 30 hours, but I don't think it is feasible in most medical colleges because of the number of students, number of patients, and plus having a patient which should correlate with what we are teaching in our subject. That may not happen. So 12 hours possibility. We may extend it to 30 hours eventually. That's the hope actually, but till such time that we can extend it, we should be relying on the paper cases or whatever video the thing. Although as the previous speaker, Dr. Dimpy, I believe, was saying, connectivity with the students with videos and all is much lesser, because one more aspect of ECE is also they learn how to connect with the patient. That is the main reason for early clinical exposure. That whole purpose is lost if you are showing them a video, because they again fail to connect with the patient. So thank you, ma'am, for this opportunity. Just adding my 2 bits of thoughts. That's it.
Ma'am, your addition, your input has been wonderful. You have, in a short nutshell, you have encompassed what is ECE actually. So thank you so much for your input. In fact, Dr. Angela and myself, we were having a discussion before my session a couple of days back. And she did say that the preclinical faculty should be involved in ECE sort of, and there was no need for input from the clinical faculty. And I was
True.
insisting the clinical faculty also can be involved, and it would be team teaching, collaborative learning, because the
No,
students
they
do
can get involved, but the main input will be
Yes.
towards our subject, not their
Yes.
subject inputs. That's
Correct, ma'am. Thank you so
Thank you.
much, ma'am, for your input.
Yeah.
Dr. Rajesh. Dr. Shantini Shanmugan. Dr. Rajesh, there is some problem in your audio. Dr. Ravi Bhaskar.
Am I audible now?
Yes.
Good evening, madam.
Good evening, sir.
Madam, I'm Dr. Rajesh here from SLIMS. Madam, a small doubt regarding one of your slide in that plan for conducting the ECE. You mentioned about the reflections for 30 minutes. Is it regarding the feedback which you are getting from the students?
Yes, the students reflect on the session that they have just undergone.
Okay, madam. One more doubt regarding that linger case, whether it is a real case or we are constructing a case, which because we have to continue it till the end of the this BBS course. No? So whether it is a real case or we are just
You can,
constructing.
it would be very, no, it would be very nice if you can get a real case from the ward. But you can construct a case as well. You could use either method.
Okay, madam. Okay, thank you.
Thank you.
Dr. Ravi Bhaskar. Please unmute yourself. And Dr. Shantini Shanmugan.
Good evening, sir. Good evening, ma'am.
Good evening.
And that was a wonderful presentation, ma'am.
Thank you.
Ma'am, I have a doubt regarding this clinical sciences. That is for 12 hours, no, ma'am?
Yes.
So
Yes,
do we have any criteria how to select the departments where the students can be divided and sent?
There is no criteria as such, but you can find out what is feasible in your setup. Like you're from Pondicherry, right?
Yes, ma'am.
So there might be certain cases which are more prevalent in Pondicherry. You have more number of cases. So based on that and where clinical correlation with basic sciences can be done. Just now we have heard how basic science is more important than the clinical case. So you could choose any topic, I guess. Whatever is
No,
feasible.
ma'am. Ma'am, this clinical sciences, what we understood is we have to send a student to the hospital.
Yes.
12 hours. Hospital visit.
Yes. Yes.
So in that case, we cannot send all the 150 students to a single department.
Right. At a time.
At a time.
Yeah, you can divide the students into batches.
Yes, ma'am. So what we did, we divide into 30, one batch, each batch 30. So we selected some 5, so 5 3s are 15, 5 departments, and we sent the student, ma'am. So what I want to know, is it anything criteria or anything that these departments mandatory to be sent like that?
There is no mandatory as such. Even the sessions, MCI just gives a guideline on how to conduct. In fact, you can divide the students into 3 batches, and you can rotate the students in the departments. So could you manage 5 departments? Was the time adequate? in the 3-hour session?
Yes.
Hello?
Yes. So I think
Sir, can you hear me, sir?
yes.
Just that is the thing, ma'am. So we selected all these departments and one to OBG. So they went with an checklist. Yeah, previous itself we have got permission from all those departments. We sent them. So while choosing, we had some little confusions, which department to include, which department to omit. Blood bank also they went. So this blood bank, it is overlapping with physiology. So we had a little bit confusion, ma'am. So that I want to know whether we have anything that we should select these departments. These like that.
There's no criteria that you have to, but you can do a lot of planning before you send the students. You can have this curricular subcommittee meetings where all the faculty members of all
Okay.
3 departments are involved. You can discuss with the clinician, you know, like what are the most common cases and updated knowledge about current illnesses and how anatomy can be correlated, where the importance of anatomy is more in those particular clinical cases. So you could choose those departments and those cases.
Okay, ma'am. Thank you so much, ma'am.
Thank you.
Thank you.
Dr. Bala Chandra Narasimhaya. I think this will be the last question. Yes, Dr. Bala Chandra. Hello. We can't hear you. So I don't see any more hands. So I think we can close it now.
Okay, sir. Thank you so much, sir. Thank you, all the participants. Sanjay, sir, thank you so much, sir, for giving the
Thank you,
opportunity.
Dr. Deepti. Excellent talk.
Thank you, sir.
As usual.
Thank you, sir.
Yes.
Okay, sir.
So the discussion will continue on WhatsApp group. So good night for now.
Good night, sir. Good night, everyone.